Hello, and welcome to the Musella Foundation Brain Tumor Awareness Month webinar series. Tonight's special guest speaker is Dr. Leland Hu. Dr. Hu is a distinguished neuroradiologist and also a program director for the MD PhD Medical Scientist Training Program at the Mayo Clinic in Arizona. At the end of Dr. Hu's presentation, I think we'll also get to hear from a patient and caregiver duo who have kindly volunteered to share their own case example using FTB maps. Dr. Hu, thanks for joining us. Please take it away.
Awesome. Thank you. It's a pleasure to be here and super excited. So go ahead and get started. These are my financial relationships. Um, so I wanted to start off by saying I think we're all, anybody involved with, the care of patients with brain tumors, I think we all understand the role that contrast enhanced MRI plays in response assessment of patients with brain tumors, specifically with glioblastoma or GBM. I think that, um, sorry, let me just pull this up. These are just two examples of patients who were diagnosed with glioblastoma. You see here in the top row and in the bottom row. And they both, this is sort of imaging at the time of initial diagnosis, and they both underwent gross total resection of that contrast enhancing core. So these are postoperative images, and they both underwent standard chemo radiation therapy following gross total resection with standard Stude protocol temozolomide and radiation. Subsequently, they both developed these abnormal contrast enhancing lesions, which by convention we would classify as tumor recurrence, and subject the patients to either more treatments or a change in treatment or surgical resection. In both of these cases, actually, the patients underwent surgical debulking and histopathologic diagnosis of these lesions. And so what we see here is one of the limitations of a conventional MRI, which is that there's a lot of difficulty in using the presence of contrast enhancement to assume that something's tumor, because oftentimes post-treatment effect, which represents a positive response to treatment and a good prognosis, can actually exactly mimic a recurrent tumor on contrast enhanced MRI. So the top patient actually had predominantly post-treatment effect. You can see the difference in survival in this patient compared with the patient below, which had predominantly tumor. And so we can see the survival difference. And so it's, again, important for us on the clinical side to understand how we can distinguish post-treatment effects such as pseudoprogression and radiation necrosis from recurrent tumor, because it does impact clinical decision-making, outlook for patients, and clinical management decisions. So this has really motivated us in the imaging world to pursue other advanced MR techniques to provide a complement to conventional MRI. And it's not to say that we're trying to replace conventional MRI, but we can helping sequences to and imaging techniques to help us improve that diagnostic accuracy and specificity. And so this has motivated a lot of us in the field.
Dr. Hu, I'm sorry to interrupt. I just going to pause you for a second.
Sure.
The sound is breaking up.
Okay. Um, Maybe I'll try to go off my AirPods, maybe. Um, is that better?
Yes, much better. Thank you.
Cool. All right. So it was just the AirPods and Bluetooth. So sorry about that. So anyways, yeah, we're all motivated in the field of advanced imaging research to use techniques besides conventional contrast enhanced MRI to help improve diagnostic accuracy. And so I'm sure if you all have tuned in to these talks and have had Kathleen Schmeida on as a guest speaker, you all probably are very familiar with the technique dynamic susceptibility contrast, or DSC perfusion, MR. And we have basically been trying to develop this technique and validate it is to bridge the diagnostic gap. And the basic premise here is that tumor in general has high microvessel volume, which means that it's not necessarily the leakiness of the vessels, but it's the size of the vessels, the overgrowth of the vessels that we're able to measure. And that increase in microvessel volume translates to a large response to the contrast bolus injection that we measure on DSC perfusion MRI. And that translates to a large measurement of what we call relative cerebral blood volume, or RCBV. And so this is an example of the GBM case with when we give that rapid bolus intravenous contrast injection, we see this large signal drop over time that tells us that there's high microvessel volume, and we measure that by these colorized maps. And in distinction, this is an example of a case where if you have post-treatment effect, or like a less aggressive disease process, which has much lower microvessel volume. So you can see here these very delicate blood vessels. You're going to have a much smaller drop in signal response related to that bolus contrast injection, and you have a low RCBV. So it's this difference in microvessel volume that we exploit on a clinical basis to try to give us more specific information and to improve the diagnostic accuracy of otherwise non-specific enhancing lesions. So in theory, this should all be very straightforward. If a lesion that's enhancing has high RCBV, then it's tumor. If it has low RCBV, then it's post-treatment effect. All right. But I will say that, again, for all of us that are involved with clinical diagnosis and treatment of these patients, oftentimes it's not this straightforward. And so this next case sort of illustrates one of the challenges or some of the challenges that we face on a clinical basis in making this diagnosis. So here is an example case of a 52-year-old male with a right temporal mass. It underwent surgical resection. It was diagnosed as a GBM. The patient underwent standard gross total resection as well as adjuvant temozolomide and radiation. And we can see here the mass over time as we continue to follow on surveillance imaging. We see that there's this progressive enlarging enhancing lesion in the right temporal lobe. So again, our job as clinical radiologists is to say, is this recurrent tumor or is it post-treatment effect? So we get the DSC perfusion, expecting that that'll basically help us solve this problem. So we get a mean overall value, as you can see here, which is, kind of the prior conventional approach. And if you take the mean value over the entire enhancing lesion, you get a mean value of about 1.05. So that's squarely in the middle of ambiguity. It's neither high nor low, it's somewhere in between. And so we're really left with sort of a coin toss of, okay, we're back to kind of square one. Is this tumor or is it post-treatment effect? In this case, it wasn't right or wrong. It was actually both correct and incorrect, because this patient actually got two different biopsies from two different locations. The first one showed recurrent tumor, and the second one showed post-treatment effect. So essentially, we would have been right either way if we called it. But there are a few take-home points from this that this case illustrates. The first is that even based off of biopsy confirmation, these lesions are not typically one or the other, meaning we can't look at a lesion and say, oh, that's all tumor or it's all post-treatment effect, because they're oftentimes a variable histologic admixture of both. And that histologic admixture is actually regionally specific, meaning that if you take a biopsy from some region and you don't document where that biopsy came from, it's not necessarily representative of the entire lesion as a whole. And so that can lead to sampling errors where you might think that you're representing the whole lesion based off of one biopsy, but it basically can be misleading. And the final point here is that, especially in this case, the use of a single RCBV value over the entire lesion can lead to non-specificity because it doesn't necessarily capture the regional heterogeneity within these lesions. So a lot of these issues have come into play when we look at previously published studies in the literature that are trying to establish whether or not DSC perfusion is helpful. And so this is a study that I've cited before. It was performed over 25 years ago, and up until recently, people were still kind of pointing to the study as to say whether DSC is helpful or not. So what they did was they took a cohort of, I think, about 20 patients, and they grouped them into either the tumor group or post-treatment effect group based off of whether they had a non-localizing biopsy, or sometimes they didn't have histologic confirmation and they used just imaging follow-up to say, okay, if the lesion was growing over time, let's call that tumor. If it stays stable or regresses, then we're going to lump it into the post-treatment effect group. So once they grouped that, then they measured RCBV over the entire lesion, again, using a single mean RCBV. And then they said, okay, let's see what the degree of overlap is, or what's the separation between the tumor and the post-treatment effect group. And so their conclusion were that, yeah, RCBV is helpful at the very extreme values, but there's this quite a bit of overlap over a range of RCBV values that is non-specific. So their conclusions were really that it's not super helpful unless you have those kind of outlier cases. And they actually recommended that you pursue other techniques like PET or MR spectroscopy. And so unfortunately, papers or the methods of validation like this have sort of painted a bad reputation of DSC and sort of underrepresented how useful it can be. So let's go back to our 52-year-old male patient with the right temporal mass. So this is, again, that case of a recurrent lesion that showed two different areas, one with tumor and one with post-treatment effect. So as it turns out, we actually recorded this stereotactic location of where biopsy 1 and biopsy 2 came from. So biopsy 1 we see here came from this area along the intromedial aspect of the lesion. And when we look at the biopsy results, that was the biopsy that showed the recurrent tumor. And in fact, if we get a localized RCBV measurement that basically corresponds with the location of where that biopsy came from, we actually get an RCBV value of 1.81, which is well above that mean value of 1.05, if you recall, when we averaged over the whole lesion. Meanwhile, if we look at biopsy 2, that came back as post-treatment effect. And if we measure the RCBV from that location, we get 0.61, which is well below that mean overall value. So all of a sudden, we start to, when we look at the spatial matching of the RCBV values relative to where the biopsies actually came from, we start to achieve this really nice separation between tumor and post-treatment effect RCBV values. And so we can actually have a lot more confidence to say that, hey, in this particular region, we think that there's tumor. And in this particular region, there may be post-treatment effect, and they may coexist in the same lesion, as opposed to kind of lumping and grouping everything together. So what we can do is then use that threshold to differentiate biopsy samples, but we can also extend that threshold value to classify all the enhancing regions within a particular abnormality. So what that means is that we can diagnose each voxel individually and separately. And so that's essentially what fractional tumor burden maps or FTB maps are. So here what we've done is we've said, okay, let's take all of the enhancing voxels that have an RCBV below 1.0 and let's color them blue. And then let's take all of the enhancing voxels that have an RCBV above 1.0 and let's colorize them as yellow or red. So yellow is just, moderately elevated, red is super elevated, but the point is that tumor represents the sum of the yellow and red voxels. And so all of a sudden, this allows us to understand the spatial localization and extent of tumor relative to admixture of post-treatment effect. And it allows us to quantify, based off of the relative abundance of blue voxels versus yellow and red voxels, how much tumor there is versus how much post-treatment effect there is. And so it basically provides a more specific classification based off of just the enhancement alone. So we found that the quantification of tumor voxels correlates nicely with the neuropathologist's quantification of tumor abundance based off of surgical resection samples. And so we showed that in a previous study in 2012. After that, Kathleen Schweinde's group published a very nice study further confirming that threshold of 1.0, but they also showed or introduced another technique called standardized RCBV, which gives essentially equivalent measurements to how we acquired RCBV, which was where a user kind of defined normal appearing white matter regions and normalized the RCBV for each patient. The nice thing about standardized RCBV is that it can provide very consistent measurements of RCBV that are essentially completely automated without any need for user input. So if anything, it removes that user variability. And for us, this is what we use clinically at Mayo, and it's really been a game changer from a workflow feasibility standpoint, because we don't have to have the radiologists or technologists creating maps. They're just automatically generated. So, subsequent to Kathleen's study, we wanted to further validate standardized RCBV measurements in our cohort of image localized biopsy samples. So we performed a follow-up study in 2020 where we compared FTB using normalized RCBV versus standardized RCBV, and we found very nice agreement between both techniques. So that basically proved to us, at least internally, that we could have confidence whether we're doing normalized or standardized RCBV. But since standardized RCBV is much easier to do, then that's why we've sort of shifted over to that method. And so these are just a few cases from a few different patients where we sampled different regions of the FTB map. So the point here is that in patient 1, if you take a biopsy sample from an area of blue, then you're not going to expect much tumor presence at all. And this biopsy showed 0 tumor and it was all post-treatment effect. If you surgically target areas that are admixed, they're sort of at the margins or borders of tumor and post-treatment effect, then you're going to expect to find an admixture of both. And for areas that are biopsied that are predominantly red, in yellow, you're going to expect a high abundance of tumor from those biopsies. So again, it shows a couple things. There's a lot of variability in the amount of tumor content depending on where you biopsy from, but also that these non-invasive maps can potentially guide surgeons to isolate if they're interested in getting a high abundance of tumor, whether it be for molecular profiling of recurrence or just to confirm suspicion of clinical diagnosis, then it allows them to kind of target those areas of high likelihood of being tumor. And it's nice that we've seen other groups also take on the use of FTB and incorporate it into their clinical workflows. This top study is from Michael Ives' group at Stanford, and they've shown that it informs their clinical decision making. This is another group from Netherlands showing FTB can increase the confidence of clinical diagnosis. All good things. But I think there is certainly sort of next steps in future directions for FTB. I think there's potentially clinical value in quantifying the amount of tumor to understand how this relates to overall survival and how it might fit into clinical management decisions. I alluded to the fact that there is some survival difference between patients that had all tumor and all post-treatment effect, but what if you have 25% tumor versus 75% tumor? Does that actually matter clinically in terms of differentiating that amount? And I think that's still a question that needs further parsing out. There's data certainly that suggests that the more tumor you have, the worse your prognosis. So this is a study from Forsyth et al. It was published back in 1995. All they did was sample different areas of an enhancing lesion and quantify it histologically. And what they found was that the more post-treatment effect that came out of the biopsy samples, generally the patients survived longer. And the more tumor that those biopsy samples showed, generally the patients did worse. But again, I think the total number of patients there was 50. We, in our cohort published in 2012, also found that histologic tumor fraction, as well as non-invasive quantification using FTB maps, did show a correlation with overall survival, meaning that the more tumor that was shown either on FTB or based off of histology, generally the patients did worse. But huge caveat here is 25 patients in our study, 50 patients in previous studies. So it's a fairly small sample size. So I think the next steps of what we need to really consider are really incorporating techniques like FTB or any other techniques that can quantify tumor abundance, put them into large-scale multi-institutional clinical trials where we are controlling treatment arms to make those uniform, where we are consistently getting very good clinical annotations of treatment outcomes, and really make sure that we level the playing field and assess in a very objective manner where FTB or other techniques fit into prognostication. And it's only after that that we can really kind of understand where FTB kind of fits in the scheme of clinical management. So again, some of the takeaways from this are that we need to start moving away from this binary approach of looking at an enhancing lesion as all tumor or all post-treatment effect, because oftentimes it's a variable histologic admixture of both. Fractional tumor burden, as we talked about, is a method that provides the ability to quantify not only the amount of tumor, but look at the spatial extent of where tumor is relative to post-treatment effect and otherwise non-specific enhancing lesions. I think an important note is that we need to start holding validation studies, whether it be for DSC perfusion or validation of other imaging techniques, given the very common intratumoral and spatial heterogeneity within tumors like GBM. We really need to start expecting validation studies to use techniques like image localized biopsies to provide that spatial matching between localized imaging measurements and the multi-regional biopsies to really kind of cut down on the high incidence of sampling error that can lead to sort of misinformed conclusions that then propagate and misinform sort of clinical recommendations and paradigms. And then we spoke about this. Hopefully, we can start infusing FTB into future clinical trials as a way for us to confirm where quantification of tumor burden fits within the scheme of clinical management. So I think that's the end of my, I guess, didactic talk. And then we can go into kind of the other clinical case, but I'm not sure how you want to structure this.
Yeah, if you want to give Samantha and Tim's sort of case report as an example, and then we do have some questions coming in for a Q&A after that.
Sure. Okay, so I can share again, and then I basically just kind of downloaded the slides.
Okay, and Samantha and Tim, if you want to turn on your video and audio and just give a brief overview of kind of your diagnosis, treatment pathway, and kind of where these images are coming from.
For sure.
May I go ahead?
Yep.
Okay, so Tim was diagnosed with GBM in October of 2022. And then he had surgery a week after, they determined that he had a brain tumor. Then he had a second surgery in early November. Following that, he did the Stewart protocol and then finished that up in January of 2023, and then started the 523 of TMZ and had a recurrence then in March of 2023. Went through surgery again. And then in May of 2023, he started a clinical trial of gallium multilate. And that's kind of where we are still to this day, continuing the trial.
To follow up on Dr. Hugh, on your slides, I've been having contrast MRIs for my brain scans for the last couple of years. So my oncologist, Dr. Connolly, we've been going through those as I've been having scans, and it's been they've all been stable, but it's been very useful to see. I haven't had any recurrence or any new growth, but it's been very useful to see the blues and the
colors.
The colors. She
Yeah.
describes it.
Okay,
Yep.
Dr. Hu, do you want to kind of show us the progression over time of the FTB map?
Sure. So I just want to make sure that I have the right slides, but this is, I apologize for the overlapping font here, but it looks like this is a day 16 and day 56. I believe that the post-gallium time point was at day. It was after day 56. Is that right? And we see that after treatment that there's been sort of this persistence of the blue basically showing a predominant post-treatment effect, even though the enhancement itself was appeared to increase over time, that the FTV maps are at least providing, specificity to that enhancement, that we don't necessarily have to worry as much that of that growth, because we can see that enhancement represents predominant post-treatment effect, or that sort of positive response to treatment. And so this is basically just showing this, that overall this area posteriorly was predominant. That actually was predominant tumor back here at day 64. And then as we progress, that sort of enhancement is regressing over time. So as we go further out, there's certainly much less of that red, if any, which is, from an imaging standpoint, is very encouraging, and hopefully that fits with, the clinical picture of how you're feeling as well.
Absolutely. Yep. He has been feeling great, doing really well. Mm-hmm.
That's great to hear.
Yeah.
And for anyone that's not familiar with the FTV maps, or this is kind of the first time you're seeing these types of images in this webinar, on a normal, T1 MRI that you would look at, all of the colored area would just appear as white, and you wouldn't have this differentiation in colors, so you wouldn't know what you were looking at. We do have some questions, so I'll try to quickly go through that. I think most of them are for Dr. Hu, but we may have one or two for Samantha and Tim. So, and you may have mentioned this, but just to make it crystal clear, so what's needed in terms of imaging in order to create the FTV maps? You have to have like a regular gadolinium enhanced, MRI, and then a perfusion MRI?
Yes. So generally, so I'll back up and say that in 2020 there was a well, I'll go back even further and say that there's like a lot of different varieties of how you can perform DSC perfusion. And in the literature there, you could see that some groups were using some methods, and maybe other groups would vary that up. And so there was this concern that how you perform it may alter your RCBV values. And so to alleviate that concern, there was a group of researchers, myself included, as well as Kathleen Schmeinde. The paper was actually headed by Dr. Jerry Boxerman at Brown, but we all got together, put all the evidence together, and came up with recommendations of how to perform the DSC perfusion. And the recommendation that we gave was allows for acquisition of the DSC perfusion within the context of just your normal brain scan. So it doesn't require any additional gadolinium contrast agent. It basically just requires a power injector. And then the pulse sequence itself is something that is very widely available. So if you just look at that paper and those guidelines, your MR physicist or technologist should be able to basically punch in the right values and sort of cook up the sequence and be able to acquire it. So I'm sorry, go ahead.
I was going to ask, does the MRI machine matter? Like, does it have to be a 3T versus a 1.5T? Or?
Yeah, that's a good question. So all of the measurements that we validated on were 3T. So I think that is certainly preferred. If you do get a sequence from a 1.5T, it's not to say that it's not useful, but There may be some variability in terms of the actual 1.0 threshold. I think it will still give you, in general, a pretty good indication of areas that tend to be higher in RCBV. They're going to show up high, whether it's 1.5 or 3T. But for the greatest precision and sort of in keeping with what's been validated, what's been published on, 3T is generally preferred.
Okay. And you mentioned it's been used, FTB mapping has been used in clinical trials. Do you have like a rough estimate of how many clinical trials it's been used in so far or is being used in currently?
Yeah, I think, in terms of large scale clinical trials, I think that's a kind of a future direction, meaning that to date, there aren't really many clinical trials that have employed FTB yet, but I think it's primed to be used. And I think that's sort of my call to arms, so to speak, that I would like to have clinical trials incorporate this. And a part of it has to do with just getting those clinical trials organized to acquire DSC perfusion on a regular basis during post-op, because a lot of times, believe it or not, despite this technique being super useful, there are still a lot of practices out there that are not acquiring this on a routine basis. And we've recently put out a consensus paper in AJR in, I think it was published like 2024, but we sort of came down hard on the controversial decision to recommend that everybody acquire DSC perfusion in the routine response assessment in GBM, because I think it is that useful of the technique, and I think it's something that people should, groups should consider adopting as routine care.
Yeah, it's a great example of one of the many frustrations of patients is how slow adoption is for new technologies, and that's just for the DSC perfusion, but for FTB mapping for patients that want to access that in their regular clinical course, is it readily available anywhere outside of maybe Mayo, Arizona? Is it being used routinely in clinical practice at some locations?
Yeah, I think DSC perfusion, I will say that Mayo in general, Mayo Rochester in Arizona are definitely, they acquire it routinely. I think that other groups are starting to use it more frequently. I know Barrow, hopefully other sites. But yeah, I think there's still a ways to go, I think.
Okay, but as long as they are doing that imaging, theoretically, they could also then do FTB maps post-processing.
Yeah, look, like conventional MRI is the standard of care for response assessment. Every patient generally gets an MRI, contrast enhanced MRI, every 2 months during the course of their treatment and post-treatment follow-up. Based off of that consensus paper, it was published in Neuro-Oncology in 2020. The lead author is Boxman. Those consensus recommendations tell exactly how you can incorporate DSC perfusion during every 2-month follow-up MRI. So in theory, it's available to everyone. It's just a matter of their decision whether or not to acquire it or not.
Okay, and specific to doing these FTB maps, is this something that if patients try to access this, that's something that would be covered by insurance? And if not, how expensive is it?
So that's a good point. So there is an additional charge related to the perfusion in the analysis. If you compare it to the overall cost of the MRI itself, I believe it's just kind of a fraction. Maybe it's like, don't quote me on this, but on the order of like maybe a 25% additional charge. Okay. But I think, we've kind of argued this back and forth. Is it there are potentially savings where you have a definitive diagnosis off of that one scan, whereas if you have a more nonspecific diagnosis, then you may have to kind of get, several additional scans or be called back in an earlier time point to become a little bit more definitive. And so we feel that if you're requiring perfusion at every scan, that the definitiveness of that diagnosis actually could potentially lead to greater efficiency and overall, cost savings. There is, with the FTB method, it was developed through my collaboration with Imaging Biometrics. And so that's pretty much the kind of the platform that FTB is provided through at this point. So to my knowledge, I'm not aware of other platforms that use it, but it's essentially based off of the thresholding technique. So in theory, it could be done, but all of the validation that's been published has been through, the IU software.
Okay. And if a patient, because we talk to patients every day that, they do have these indeterminate scans, and it's a matter of their treatment decisions one way or the other. And so as a practical logistical point, if somebody wants to, if they have the perfusion scans and they wanted to get an FTB map done tomorrow, what would they do? Who would they talk to?
I think they would talk to wherever either their neuro-oncologist or their neurosurgeon, who then probably communicates with their neuroradiologist and say,
Okay.
hey, we'd like to do a DSC perfusion scan. They can point to, the papers in the literature and say, these papers sort of outline how to employ it. And we're interested in getting that to provide more specificity of our diagnosis.
Okay, perfect. Can you use FTB maps to aim stereotactic radiosurgery?
Yes, in theory, you can, because it can import or it's overlaid on the stereotactic MRI that is used to guide radiation therapy. So in theory, yeah, you can do that.
Okay, and has it been used in pediatrics in DIPG or DMG to tell if the tumor is responding to treatment?
Yeah, so those we have not applied our validation to those disease types. I believe that in general, DIPGs are not, they don't show as high an RCB value. So it's going to be a little bit more challenging distinguishing tumor from post-treatment effect in those cases. And we just haven't been able to validate, simply because in those scenarios, it's really uncommon to actually go in and biopsy. The brainstem itself is very susceptible to injury. Every part of it is high value real estate. And so it's hard to get biopsies, and really we wouldn't feel comfortable developing the technique if we didn't have sort of ground truth in the biopsies. So
okay. And a question when you're talking about the validations, is this validation that's been, discussed and approved, whether formally or informally, like from the FDA or?
It basically has been just published in the literature. So
Okay.
what we, when we talk about validation, you have the imaging technique, which is sort of the experimental, and then you have the histopathology, which is the ground truth, which is from the biopsy. And so whenever, the context of my talk, when I talk about validation, is really validating the imaging versus the ground truth. We haven't, I haven't personally ever engaged FDA on any of this. I think Ivy probably has. And so they might be able to provide literature on, their discussions with the FDA.
Okay.
That's outside of my scope.
Okay. And how does FTB mapping work in a patient that is being treated with Avastin? Would that affect the accuracy of the FTB maps?
Yeah, in theory, it does. So in general, literature has kind of pointed to the fact that Avastin reduces the leakiness of the blood vessels. And so you certainly will see a decrease in the overall enhancement. And since the FTB is kind of a function of that enhancement, they will be affected. In those cases, you would probably have to extend RCBV into the kind of the non-enhancing tumor as well, because most of the tumor or areas of abnormality will no longer enhance. And so most of our studies have not looked at in the setting of Avastin. And so it's difficult for us to really extend it in those scenarios. From clinical experience, I will say that areas that we do see recurrence, the presence of tumor even after giving Avastin, a lot of that tumor is non-enhancing. And in general, they still tend to show elevated RCBV. And so from just a anecdotal standpoint, we still use perfusion. It may not be in the direct quantification context of FTB, but in general, we still promote or recommend obtaining DSC perfusion even in the setting of Avastin.
Okay. And just as a follow-up on that, would steroid use have any impact on?
Yeah, I think steroid is similar to Avastin as well. I think Avastin is just kind of considered a super steroid.
Okay. And I think that's all of your questions. And then Samantha and Tim, if you're still on, we just have one question for you. So Tim, if I heard correctly, so you've been on the phase 1 gallium maltolate trial now for 2 years. Have there been any side effects of that treatment for being on it for so long?
No, I take 3, and they're pretty big pills. I take them every morning at 6 o'clock, and 2 years I've taken, feels like 1,000 pills. No side effects. All good.
It's great to hear. And it's so neat to look at the images.
Yeah.
Oh, wait, there's, okay, yeah. In our questions section, could Tim and Samantha speak to their gallium maltolate experience, dosage, any side effects, what the experience was like? So no side effects, good experience, obviously good imaging. Is there anything else you want to share?
Just he's on 1,500 milligrams a day.
Yeah.
So he's been on that consistently. May 25th will be his 2-year anniversary on the trial. Yeah.
Is there any plan to wean off or stop at any point, or is it just continuing indefinitely?
Continuing indefinitely.
Yeah, not until that little 2.8% goes to 0.
Okay, awesome. All right. I think that's all of our questions. Thank you so much, Dr. Hu, for presenting and answering all of our questions. And thank you so much to Samantha and Tim for sharing your imaging and sharing your experience.
Thank you for having me.
Thanks, Samantha and Tim. That was really nice. And back to you. Vanessa, could you just talk about the next webinar?
Yeah, we have 2 more webinars in the month of May, and then we just scheduled another one for June. But we have one coming up this Sunday with Dr. Bert Neighbors from UAB on glioblastoma beyond the guidelines. And then we have another one later towards the end of the month with Dr. Nick Vitanza on CAR T treatment. Looking forward to that. Please join us. This webinar will be recorded and made available on the virtualtrials.org website. Thanks, everyone.
And good night, everybody.
Great. Thank you. Bye.
Thank you.